بسم الله الرحمن الرحيم. Dear colleagues, I will like to welcome you with me here in the coming minutes. I will explain to you and try to teach you a practical approach of brain tumors imaging. I'm Abdelaziz Naqidi. I am a professor of radiodiagnosis in Alexandria University. Actually, what I have done in this lecture is to rearrange the tumors into groups as if we are approaching them in a differential diagnosis pattern. In each tumor, you will be able to know the imaging features and to see some common and some rare imaging features patterns, as well as common and rare tumors. And of course, I will try to include the new additions of the new WHO classifications of brain tumor 2016 into these groups. I think that you have already known how we can analyze a potential brain tumor or space occupying lesion. I think Dr. Aya has explained them in lecture before. The items we use to analyze are the age of the patient, because there are tumors specific to certain ages, location, intraaxial or extraaxial one, or midline, the MRI and CT characteristics of the tissue matrix and the composition of the tumor. We use a lot of parameters, and of course, is it enhancing or not? And we describe also the mass effect, the anatomical location, the edema surrounding, and so on. So by applying these items, we will fulfill complete description of a tumor, and of course these characteristic features can help us to reach a diagnosis or to narrow the differential diagnosis list. I will use these items in most of the tumors. I will explain. We will speak about the age, location, the tissue matrix, including the CT and MRI criteria. Is there cysts, calcifications, hemorrhages, enhancement, edema? What about diffusion weighted, perfusion, special features, if we have certain MRS features, and sometimes we can give a key to tell which in these tumors. Let us start with the first group, which are the brain stem tumors. We have a lot of brain stem tumors. Most of them are named after their anatomical locations or behavior. As you see, we have tictal glioma, focal midbrain tumors, focal intrinsic pontine glioma, diffuse pontine glioma, dorsal exophytic glioma, focal medullary glioma, cervicomedullary glioma. Okay. Let's start with the first one, diffuse pontine glioma. From the name, it is diffuse, pontine, it involves the bones, and it is a glioma. The mean age of this tumor is 7 years old. It is a mass markedly expanding the bones, so it is located in the bones. And because it is markedly expanding, it may engulf the anteriorly located basilar artery, but doesn't invade the fourth ventricle, and it may obstruct it. Regarding the tissue matrix, ill-defined, homogeneous, and may appear early circumscribed. So as you see, this is an ill-defined hypodense lesion expanding the pores. And as you see, it is more or less engulfing the basilar artery. In the CT, it appears hypodense, T1 hypointense, T2 and the flare hyperintense. Cysts are uncommon to be seen, rarely calcification, rarely to see hemorrhage. Usually it doesn't enhance, but we can see enhancement usually of the exophytic component, and as the patient receives treatment and stay along in life, there is increased enhancement and necrosis. Edema is, of course, surrounding it. Let us see. Okay, expansile lesion infiltrating the bones, and as you see, it is engulfing the basilar artery. Okay, expansile lesion involving the bones. It occurs that this may simulate brainstem encephalitis. Clinical is very important. Patients with brainstem encephalitis are usually in very bad condition with disturbed level of consciousness and so on. But patients with brainstem glioma usually present with gradual onset, long history of disturbed neurological manifestations, especially cranial nerves dysfunction and so on. So clinical is very important. Okay, this is the pattern of enhancement. It can be punctured like this, can be diffusely enhancing, can show necrotic pattern of enhancement as in this case. Again, expansile lesion with engulfment of the basilar. In the WHO 2016, a new term or a new pathology was described, which is called diffuse midline glioma, which is a specific entity. They are aggressive tumors with poor prognosis and considered WHO grade 4. Usually it affects the midline. Okay, it can involve both thalami, it can involve the brainstem, pontine, mesencephalon, it can involve the spinal cord. And as it is aggressive like this, it is associated with extensive spread, frequently both craniocaudally to involve the cerebral hemispheres and spinal cord. It appears T1 hypointense, T2 hyperintense, usually minimal enhancement, but it can enhance post radiotherapy. Usually in diffusion weighted, it is normal. So diffuse pontine glioma can be one of these patterns, which is called diffuse midline glioma. The second tumor in the brainstem is the focal tegmental mesencephalic glioma. As you see from its name, it is focal tegmental because it involves the tegmentum of the midbrain. Mesencephalic is midbrain, and it is glioma. The age is also 7 years. Usually, it is a coma-shaped tumor that extends along the cerebral crus to the thalamus. Cerebral crus is part of the mesencephalon of the midbrain. As you see, usually it is partly solid, partly cystic, or a cyst and nodule. Location-wise, it involves the crura cerebri or the mesencephalon, okay, tegmentum of the mesencephalon, and extends through them to the thalamus. It has an enhancing nodule and a cystic portion. So the matrix is cyst plus nodule, hypodense in CT, T1 hypo, T2 and the flare hyper. Calcification is rare, hemorrhage is rare. It has enhancing nodule, and edema can Again, this is focal tegmental mesencephalic glioma. An important information for you that most of the lesions that present as cyst and nodule can start in the early phase as just enhancing nodule, then it develops the cyst later on. We will see this in a lot of tumors. So we can see it as just enhancing nodule like this, and later on it will develop the cyst to become a cyst. And tumor number 3, tictal glioma. What is the tictal glioma? It is a tumor also of a childhood, around 7 years old. Okay, this is the mean age. It is a low-grade glioma, pilocytic focal lesion that expands the tictal plate. What is the tictal plate? The tictal plate is the posterior aspect of the midbrain. These tumors are very important. Why? Because they are very small when they start, but they present by early obstructive hydrocephalus. Why? Because these tumors are in close relation, just posterior to the aqueduct of Servius. So they can cause obstructive hydrocephalus, and usually the patients present with this obstructive hydrocephalus. Usually in CT, as you see, the patient presents by obstructive supratentorial hydrocephalus, and we go to do CT. Usually we don't see nothing because the tumors are very small. But if you have a child with obstructive hydrocephalus at the level of the aqueduct, you should go to do MRI, because most of the lesions are small like this and iso-intense, but later on these tumors build up calcification and become hyperdense in CT, so you can detect them in CT, but in most of cases the tumor are isodense to the brain and you cannot discover them. So you must go and do MRI. So the tissue matrix is ill-defined homogeneous. CT is iso to hazy increased density over time. Hydrocephalus is common. T1 is variable according to the presence of calcification. It could be hypo, hyper, iso. T2 and the flare could be hyper or iso. Uncommon to see cysts with this tumor. Calcification occurs with time, rarely to see hemorrhage. Enhancement is variable. The tumor is very small and it is surrounded by CSF, so edema is uncommon. And the key is hydrocephalus. Go and do thin cuts to look for the presence of tumor in the tictal plate. As you see, focal expansile lesion. In the flare, it is hyper intense, okay? And in T1, it may be iso to hypo and so on. And as you see, it is obstructing the related aqueduct of Servius. It may be more large mass, very large mass like this, maybe heterogeneous and heterogeneously enhancing. But commonly we see it in the very early stage as a small tumor because the patient presents with hydrocephalus. Another tumor of those of the brainstem, which is dorsal exophatic glioma or dorsally exophatic glioma. It is a tumor originating from the medulla or the bones, and it is exophatic posteriorly, so that it is called dorsal, and it may bulge into the fourth ventricle like this, or bulge like this into the cisterna magna, and sometimes we can mistake it for intraventricular tumors. But actually, the main origin of the tumor or the epicenter of the tumor is from the brainstem, but it is exophatic. Take care of this tumor. This is an example of glioma involving the cervicomedullary region. As you see, expansile lesion that is infiltrating the upper cervical cord and the medulla oblongata. We have described diffuse pontine glioma. If it is well circumscribed in the early stage, we can call it focal intrinsic pontine. If it is in the medulla, focal intrinsic medullary glioma, and so on. This is just a descriptive name according to the shape and location of the tumors. This is an example of focal intrinsic medullary glioma because it is mainly involving the medulla oblongata. For those of MD degree, glioma can occur in the root entry zone of the cranial nerves emerging from the brainstem. This is an example of a glioma involving the trigeminal root entry zone. Usually, we mistake it for a tumor schwannoma or CP angle schwannoma, but actually, as you see, it is a solid and cystic, and this can occur in schwannoma also, but there is no the tumor is not that homogeneous, and on pathology, don't be astonished if you find it called extraparenchymal glioma originating from the root entry zone of the trigeminal nerve. This for dear colleagues and MD section. So let us summarize. We have a lesion expanding the bones, engulfing the basilar artery. Usually it is not enhancing or showing punctate or heterogeneous enhancement. This is diffuse pontine. This tumor involves the thalamus and extends to the midbrain. This is called focal tegmental mesencephalic glioma. It can be solid and cyst or cyst with a solid nodule, but in the early stage it starts as just enhancing nodule. This is a dorsally exophatic glioma originating from the medulla. So this is dorsal medullar exophatic. This is a very important, and you should look for the sagittal in the thin cuts for the tictal plate. If any expansion or heterogeneity of the signal in this area causing obstructive hydrocephalus, this is called tictal. Now we will go to the second group, intraventricular tumors. Number one, subependymal giant cell astrocytoma. Usually it is seen in the first 2 decades of life. The mean age is 11 years old. This tumor starts as enhancing intraventricular mass in a special group of patients, which is called patients of tuberous sclerosis complex. You know this? Tuberous sclerosis complex is one of the phacomatosis which is characterized by the presence of subependymal nodules that will calcify cortical tubers and white matter changes. It has a very characteristic picture in MRI and CT, and you shouldn't miss it. One of these two subependymal nodules located nearby the foramina of Monro. This is the location of this tumor, foramina of Monro. Become enlarged in size, and this is a threshold, 1.2 centimeter. If you have a lesion of subependymal nodule more than 1.2 centimeters, okay, you should think that it is transformed into subependymal giant cell astrocytoma. It is a benign one, low grade, so we don't see CSF spread, and I will tell you about CSF spread in the coming tumors. Okay, a tumor nearby the foramen of Monro. It is partially calcified because already it is a subependymal nodule like this, that got enlarged more than 12 millimeter and showing enhancement. This is giant cell astrocytoma. It is hypo to iso and CT, T1 hypo to iso, T2 and flare hyper intense to heterogeneous. We don't see cyst. There is variable calcification, no hemorrhage, enhancement is marked, no edema. The key here is the presence of tuberous sclerosis. Okay, presence of tuberous sclerosis is stigmata in the patient, and you find a lesion nearby the foramen of Monro, enhancing and enlarging in size. This is giant cell subependymal giant cell astrocytoma. So this is easy. Other examples, lesions may be very large like this, maybe bilateral, okay, and the patient shows the other stigmata of tuberous sclerosis. These are cortical tumors, and you can see subependymal nodules, okay, like this, and the flare is very important, and sometimes you may need to do CT to see these cortical tumors. Look, these are the other findings in tuberous sclerosis. You can see the subependymal giant cell astrocytoma, other subependymal nodules, and of course the cortical tumors, which are best seen in images. Central neurocytoma. This is a tumor that affects young adults from 20 to 40 years old, rarely to be seen in infants and elderly, but occur. We are speaking about common things. Common thing to see it in adults, but don't be astonished if you find the pathological report coming from an infant or a very elderly one that he has central neurocytoma, but this is not the common. Typically, it is located supratentorially and within the ventricle. It appears as intraventricular mass attached to the septum pellucidum. Okay. It likes the anterior part of the lateral ventricles, especially the frontal horns and the body. Okay, rarely to be seen in the third or the fourth ventricle. It is very extremely rare to see it in the fourth ventricle. Sometimes this tumor can occur within the parenchyma, and then it will be called extraventricular central neurocytoma. But we are speaking now about the intraventricular type. The clue here is to see intraventricular mass attached to the septum pellucidum and having multiple small cysts like this, giving it the appearance of a papillary mass. Okay, presence of multiple tiny cysts give it the appearance of a papillary mass, which is the clue to diagnose central neurocytoma. In addition to these tiny cysts, you can see calcification, you can see hemorrhages, foci of hemorrhages, and signal voids due to increased vascularity. Usually mixed solid and cystic, as I've told you. Calcification can be seen. Hydrocephalus is common because it is nearby the foramen of Monro, rarely complicated by hemorrhage. It shows moderate to heterogeneous enhancement and prominent signal voids, and usually it is restricted in diffusion. Okay, take care of the tumors showing restricted diffusion. This is one of these tumors. Usually it shows restricted diffusion, and as you already know, you should look for the image of diffusion and the ADC map if the tumor or the lesion is hyper-intense in diffusion and hypo-intense in the ADC map. This is true restricted diffusion. Okay, so the clue here, papillary mass, intraventricular in a young adult, showing multiple cysts, restricted diffusion, calcifications, hemorrhage. This is central neurocytoma. Ependymoma. Ependymoma has bimodal age distribution. We can see it in children in the age of 1 to 5 with another smaller peaks in the mid-30s. Okay? This tumor has the probability of CSF dissemination. We will explain that soon. 2/3 occur in the infratentorial within the fourth ventricle. Okay, it is usually originating and distinct from the floor of the fourth ventricle. 1/3 occurs in the lateral or third ventricle, and the majority infiltrates the periventricular white matter. Usually you are asked to differentiate medulloblastoma from ependymoma in the fourth ventricle. Okay, we have certain criteria that we use to make this differentiation. Number one, ependymoma is much less common than medulloblastoma, statistically wise. Number two, it is indistinct from the floor of the fourth ventricle. This is the floor of the fourth ventricle, so the interface between the lesion and the floor is ill-defined, while the roof, which is the superior medullary velum, is ill-defined if we have intraventricular medulloblastoma, because it originates from this area. Look, the floor is more or less well-defined. The roof here is more or less well-defined. Okay. Ependymoma is a tumor with a characteristic pattern of tissue matrix, which is the plastic nature. What is meant by plastic nature? It means that it can squeeze itself through the foramina, nearby foramina, to go to another space, like toothpaste. Remember this, like toothpaste. Heterogeneous, soft or plastic tumor that squeeze out through the foramina into the nearby cisterns of the posterior fossa, usually irregular shape and accommodate to the shape of the ventricle. So it will not be spherical. It will squeeze itself through the foramina to cast them. Okay, calcification is common, cysts are common, hemorrhage can occur, enhancement is mild to moderate, heterogeneous, and in FLAIR you can see sharp interface between the tumor and the CSF, and the tumor cysts are very hyperintense to the CSF. Let us see, this is lateral ventricular one, tumor with cysts. Again, fourth ventricular, it squeezes itself through the foramen of Magendie into the upper cervical region. And here, it squeezes itself through the foramen of Loschka into the cerebellopontine angle. Usually, we use this to differentiate, okay? In diffusion weighted imaging, it is rarely to be restricted, okay? Because medulloblastoma usually restrict in diffusion, but some of the ependymomas in rare cases may show some restricted diffusion. But actually we use the shape of the lesion, the pattern of spread of the lesion through the foramina of Monro and so on, plastic pattern of growth, to differentiate medulloblastoma from ependymoma. As I've told you, it can occur supratentorially. It may be within the lateral ventricles, but actually in most of cases, it likes to infiltrate the surrounding white matter. So don't be astonished if a tumor like this, which you may write it as a glioma, to have the pathological report saying that it is an ependymoma. Actually, ependymoma is a subtype of glioma, but if it is located intraventricular, it is easy to diagnose, but if it infiltrates the surrounding white matter, you can put a differential diagnosis of ependymoma or a glioma. For my colleagues in MD section, the CP angles contains ependymal cells. So ependymoma can originate in these ependymal cells as a CP angle mass. Okay, if you have a question, long question in the final exam, what are the tumors of the CP angles? The most common, as you know, is acoustic schwannoma, but we have also the possibility of ependymoma to originate in the CP angle, not in the fourth ventricle, in the CP angle sister. Medulloblastoma. Medulloblastoma, or what is called posterior fossa primitive neuroectodermal tumor, is a malignant, invasive, highly cellular embryonal tumor. 75% occurs in less than 10 years old and mostly diagnosed by the age of the 5 years. It has two areas to start in. It could be fourth ventricular tumor, which arises from the superior medullary velum, or it can originate in the cerebellum itself, which is called lateral origin medulloblastoma, and this is more common in children and young adults. It is called lateral origin or desmoplastic type of medulloblastoma. Usually we see it as a spherical mass that push the brain away on all sides. It is not plastic like ependymoma. It is highly cellular tumor. Tumors with highly compacted cells have certain criteria in CT and MRI. What is this? Usually it appears hyperdense in CT. It appears slightly hypointense in T2. Usually these are restricted in diffusion and shows enhancement like this. Because it is a malignant tumor, calcification, hemorrhage, and so on can occur in this tumor. So 90% are hyperdense, calcification in 20%, hemorrhage is rare but can occur, cyst may occur due to necrosis, it obstructs the fourth ventricle, so hydrocephalus is common, 80% in hands, relatively homogeneous, and usually there is what is known as CSF seedling or CSF dissemination. The tumor is in the fourth ventricle, so the tumor cells are shed into the CSF and can spread along the CSF to anywhere on the brain surface or along the cervical, dorsal, and lumbar region into the thecal sac, and we will see examples to explain this phenomenon. And because this tumor is aggressive and very malignant, our colleagues in the Department of Oncology usually ask to examine the brain and the whole spine to detect CSF seedlings. And you will see it on routine work. Patients with medulloblastoma or ependymoma are usually asked to perform whole spine or whole neuroaxis imaging with contrast to exclude CSF seedling. And as I've told you, because it's highly packed, highly cellular tumor, it is restricted in diffusion. This is an example, diffusion weighted of medulloblastoma. It is rounded in shape, as you see, like this, spherical with restricted diffusion. In T2, it is more or less hypointense, and it shows restricted diffusion. You remember this slide? Usually the interface of medulloblastoma is indistinct from the roof, because here there is the superior medullary velum, which is the origin of medulloblastoma, while in ependymoma it is indistinct with the floor of the fourth ventricle. This is the variant or the second type of medulloblastoma, which is called the lateral origin or desmoplastic type, and usually we see it in older children, okay, or in young adults. The same criteria, tumor, hyperdense in CT, it can be variegated like this or mass like this, and usually it shows restricted diffusion, enhancement. This is the restricted diffusion, enhancement, and it may take foliar-like shape like this. So tumor involving the cerebellar hemisphere with restricted diffusion and initial hyperdensity in CT, you should think of lateral origin or desmoplastic type of medulloblastoma. CSF seedling. As I've told you, the tumor spreads along CSF. It forms nodules like this on the leptomeninges, or sheet-like enhancement like this on the leptomeningeal surface of the brain. It may form masses like this in the cerebellopontine angle and may extend into the internal auditory canal. And the whole spine, you can see hyperintensity or hyper enhancement of the CSF like this, or nodules like this, or masses like this in the, and you can see linear enhancement along the surface of the spinal cord, which is called icing. You know icing or sugar coating, as if you are coating the spinal cord with sugar, white sugar, or it can form masses like this, and you can see masses along the coda equina or nodules. This is what is called CSF seeding or drop metastasis, and you will see it in many cases of medulloblastoma, because if you report this, the doctors are going to irradiate the whole spine. So if we are going to differentiate medulloblastoma from ependymoma, as of course medulloblastoma is much more common than ependymoma. The shape of medulloblastoma is spherical, but the shape of ependymoma is plastic, as you see like this. Okay, remember toothpaste. Medulloblastoma usually restricts. Ependymoma usually don't restrict. Okay. It is more heterogeneous in ependymoma, calcification hemorrhage, more homogeneous in the medulloblastoma, okay? And the clue, as I've told you, the shape, the initial hypertensity, and the restricted diffusion, and the relation to the roof and the floor of the fourth ventricle. Okay, this one related to the roof, this one related to the floor, or indistinct from the floor. Restricted diffusion is very important. Usually or always medulloblastoma is restricted, but ependymoma is usually not restricted in diffusion. Another tumor that originates intraventricular is called subependymoma, and this is rare, very nice tumor, benign, and has certain criteria that can help you. Usually we see it in middle to old age, not in children, okay, 50s to 60s. Intraventricular, usually it likes the fourth ventricle. It often protrudes through the foramina. It may arise from the lateral ventricle being attached to the septum pellucidum, rarely to originate from the region. The clue that it is a well-defined lesion, okay, that is hyperintense T2, hypointense T1, and usually no enhancement to just mild enhancement, okay, usually. But when the tumor becomes enlarged and more heterogeneous, you can see heterogeneous enhancement. But the clue is the age. Sometimes these tumors becomes markedly calcified, okay, giving this extensive calcification within the lesion, which is sometimes called intraventricular or brain rock or brain stone. It is benign, so we don't see edema surrounding it. Sometimes I've told you if it gets much enlarged like this, it becomes heterogeneous with areas of hemorrhage, calcification, and you can see heterogeneous enhancement. In this situation, we put in our report a differential diagnosis. It is not shame at all to write a report with a differential diagnosis, but you should write it in a wise pattern. That means that you don't write the whole list. You can exclude some of the tumors. You can put the most likely. For example, in this situation, if I'm going to write it, I will put ependymoma versus subependymoma, or sometimes a rare tube like this occurs in the fourth ventricle called rosette forming fourth ventricular tumor, glioneural tumor. I can put it. So in this age, you need to put medulloblastoma, okay? Not shame at all to write a differential diagnosis. The main rule of you as a radiologist or a neuroradiologist is to describe the tumor anatomically, where it is originating, what its effect, what it is forming in the brain. Is it compressing or infiltrating the brain stem? What its relation to the nearby structures? These are the items that the patient, the surgeons want to know. Of course, he will take the tumor out of the brain and send it to the histopathology. So it is very important to know that your main rule is the pre-surgical planning and to tell that it is a tumor. And if it is very characteristic, you can put a spot diagnosis once. Or if you are not that sure, it is not shame at all to put a narrow list of differential diagnoses that can help the clinician or the pathologist in their further work. Choroid plexus papilloma. We have certain tumors that arise from the choroid plexus, ranging from papilloma, passing to carcinoma. Usually, it occurs in the lateral ventricles in infants and children, while in the fourth ventricle in adults. So it has bimodal, children and adults. 50% occur in the atrium of the left ventricle. 40% occur in the fourth ventricle. 10% may occur in the third ventricle. Large choroid plexus papilloma may bury itself into the brain parenchyma. Usually the tumor is like this, very enhancing, attached to the choroid plexus, and characteristically it has the cauliflower pattern of appearance. A lot of clefts that CSF bury itself inside, giving this characteristic appearance of cauliflower mass. Again, cauliflower mass. This is very characteristic. And actually, it is a highly cellular tumor, okay, originating from the choroid plexus. Cauliflower-like mass of remarkable size at the diagnosis. Usually present by hydrocephalus. Why? Because it oversecretes CSF, so there is overproduction of CSF, so these patients present with hydrocephalus. Sometimes it has a mass effect obstructing the outflow of CSF. Rarely, when small, its pedicle may get twisted or torsion occur, and this lesion becomes markedly calcified and called brain stone or brain rock. 75 are isotohyperdense. Calcification occurs in 25%. Enhancement is homogeneous or heterogeneous when malignant transformation occurs. On CT angiography, we can see enlargement of the choroidal artery. CSF is trapped between the papillae, giving the mottled appearance. Internal linear and branching vascular void structures may occur. Sometimes the choroid plexus papilloma may originate in the CP angle. As I have told you, the CP angle cistern contains both ependyma and choroid plexus. So choroid plexus papilloma may originate in this area. These for our colleagues. And the counterpart of choroid plexus is choroid plexus carcinoma. It occurs between the 2 and 4th years. The median age is 26 months. Usually we see intraventricular enhancing mass, but with aggressive behavior. Usually it arises in the ventricle. We cannot differentiate it from papilloma easily, except we see that the lesion is aggressive in its behavior. It can infiltrate the nearby white matter. It can be surrounded by vasogenic edema or associated with CSF seedlings. If we see this, we can easily tell that it is a carcinoma. But in most of cases, we cannot differentiate papilloma from carcinoma until pathology is done. So you can report it is choroid plexus tumor, mostly papilloma rather than carcinoma, or if it is like this, aggressive in behavior, we can tell that it is a carcinoma. As a tip, intraventricular mass in the first year of life, you should consider choroid plexus tumors, papilloma or carcinoma. Imaging alone cannot differentiate papilloma from carcinoma unless we have malignant behavior. Newly described as intermediate between papilloma and carcinoma, a tumor called atypical choroid plexus papilloma. It is considered grade 2, WHO grade 2, and because it has earlier recurrence, sometimes with METs, and intermediate histology between papilloma and carcinoma. Okay. On imaging, we cannot differentiate papilloma from the intermediate grades or atypical choroid plexus papilloma. The same appearance, cauliflower lesion. Rosette-forming glynural tumor of the fourth ventricle. This is a rare tumor, recently described, and is a new entity and WHO 2016 classification. It is a rare, slowly growing WHO grade 1 tumor, usually affecting young adults. The mean age is 33 years old. From the name, it arises from the fourth ventricle. Okay? It is a glioneural tumor. Okay? If outside the fourth ventricle, forget it. So this is a tumor of the fourth ventricle. We see it as heterogeneous, solid, and cystic multiloculated lesion with calcification, sometimes hemorrhage creating fluid level, and this is a characteristic features with variable enhancement, usually poorly enhancing to heterogeneously enhancing. As you see, tumor bubbly like this, cysts and nodules, so heterogeneous within the fourth ventricle. You can see calcification and the very characteristic appearance in the presence of fluid level due to hemorrhage, in addition to hemosiderin deposition. This tumor is called rosette-forming fourth ventricular glioneural tumor. This tumor is similar to the medulloblastoma. It is highly malignant, which is called atypical teratoid rhabdoid tumor. It is a malignant rhabdoid tumor of the brain, rarely aggressive tumor that affects any area of the brain. It may originate within the fourth ventricle, simulating medulloblastoma. But the clue here is the age. If you see a medulloblastoma-like tumor in a child less than 3 years old, you should consider atypical teratoid rhabdoid tumor in your differential diagnosis list. because it occurs in this age. It can occur in any site, and we will see this in the rest of the lectures. But when it comes in the fourth ventricle or the third ventricle, you should consider medulloblastoma variant, which is atypical teratoid rhabdoid tumor. It almost has the same features of NCT pattern. These are the different locations. Okay, we are interested of the intraventricular, usually hypertense because of high cellularity, calcification, hemorrhage may occur, heterogeneous enhancement, restricted diffusion, leptomeningeal spread, and on MRS it has an aggressive metabolite curve that you can. Okay, these are examples of atypical teratoid rhabdoid tumor involving the fourth ventricle. Actually, it is more or less simulating medulloblastoma, but here the age. If you see medulloblastoma-like tumor in the age below 3 years, you can put the differential diagnosis of medulloblastoma or atypical teratoid rhabdoid tumor. If the age is more than 3, put just medulloblastoma versus ependymoma, as I've told you. Okay, these are other locations and in association with CSF seedlings. Atypical teratoid rhabdoid tumor involving a lot of areas. It can be within the lateral ventricles like this, okay, simulating central neurocytoma, but the clue here is the age. Child less than 3 years. Okay, it can occur in the CP angle. You can put it in the differential diagnosis of CP angle tumors in a child less than 3 years old. The last tumor is chordoid glioma of the third ventricle. From the name, it occurs in the anterior part of the third ventricle. It simulates colloid cysts, usually in C an adult, rare glioma arising from the anterior wall or roof of the third ventricle. It is WHO grade 2, likely of ependymal origin, and may arise in the subcommissural organ. They present with hydrocephalus because of obstruction of foramina of Monro, sometimes endocrine disturbance, visual disturbance because of its nearby location to the optic chiasm. Usually we see it as if intraventricular tumor involving the third ventricle, simulating what like this? Subependymal giant cell astrocytoma. But the patient has no stigmata of tuberous sclerosis. Tumor with calcification occurring nearby the foramina of Monro. Sometimes in CT, it is hyperdense, simulating colloid cyst. So if you have a colloid cyst-like lesion that enhances, think of chordoid glioma of the third ventricle, because colloid cysts don't show homogeneous enhancement. You can see peripheral wall enhancement, but not homogeneous enhancement or heterogeneous enhancement like this. This is what's called chordoid glioma of the third ventricle. Other intraventricular tumors that you should put in your diagnosis, of course, meningioma, having the features of meningioma but originating within the ventricle, glioblastoma multiforme, metastasis, lymphoma may occur ventricular, cavernous malformation, arteriovenous malformation or cavernoma may occur intraventricular, and as you see, it can present by intraventricular hemorrhage. And when we do MRA or CTA, we can see a tuft of enhancing tissues that project into the lateral ventricles. So you should know the whole list. I have told you about the tumors. There are other non-tumorous conditions that occurs intraventricular, such as arteriovenous malformations or sometimes granulomas. Differential diagnosis of intraventricular lesion in an infant, you should think of choroid plexus papilloma, atypical papilloma, or choroid plexus carcinoma. In adult, central neurocytoma, bubbly appearance. If it is not enhancing, subependymoma. If it is heterogeneously enhancing like this, you can think of ependymoma. Ependymoma. If it is so homogeneous enhancement, you can think of meningioma. If we see fluid levels and hemorrhage, we can think of rosette-forming glioneural tumor of the fourth ventricle. In children, think of ependymoma, medulloblastoma, and if the age is less than 3 years, you can think of atypical teratoid rhabdoid tumor. We will stop here and we will continue in the next lecture.